Hazen, and it's my pleasure to welcome you all on behalf of AIDPH to this month's ECHO session. This month's session is going to focus on minimally invasive care. As we get started, I want to thank our ECHO partners, the CareQuest Institute for Oral Health, the University of Nevada, Las Vegas, and the Oral Health Progress and Equity Network. So today's call, we have a packed agenda as usual. After going over some housekeeping items, we're going to have a didactic presentation on minimally invasive care. Following that, we'll have a few minutes for Q&A from participants. We'll then move to the case presentation part of our call, which will be a case from Northern Arizona University. We'll go into some breakout rooms to do discussion and offer up some advice to our case presenter, and then we'll close out. Real quick, we want to ask everyone to please put your email and organization name in the chat so we can capture who's joining us today. All slides, forms, and materials from today's session will be available on the AIDPH website following the call. We ask you to avoid any personal health information on this ECHO, and if you have any questions about using Zoom during the call, please send a chat to Annalise in the chat box. For those of you who have not been here before, this ECHO follows the CareQuest Institute's 3 domains framework, which includes teleprevention, minimally invasive care, and integrated and personalized care. Next slide, please. This month's topic, as I mentioned, is minimally invasive care. You can see here, and we also have this posted on the AIDPH website, what our call topics are for the remainder of 2022. So we encourage you to keep an eye out for those as dates and registration materials are announced. Next slide. Our session norms are that each person learns and each person teaches. Everyone uses first names to facilitate equality in the discussion. So we're going to avoid any use of the term doctor or any other honorifics. Always introduce yourself with your name, organization, and location before speaking. We ask everyone to please turn on their video, but to stay on mute until you're ready to talk, and limit any environmental distractions to the extent possible. As always, respect one another. It's okay to disagree, but do so respectfully and respect patient health information. Thank you. Any questions about all that before we dive into our content? Okay. Next slide. So it's now my pleasure to introduce this month's presenter, Jeremy Horst Keeper, who is the Director of Clinical Innovation at CareQuest Innovation Partners, an organization whose mission is to improve oral health for all by advancing innovation to transform access and outcomes for underserved populations across the U.S. As a practicing pediatric dentist, biochemist, and educator, Jeremy is known for investigating the strengths and limitations of silver fluoride therapy, helping to develop smart fillings, and accelerating the adoption of maximally effective, minimally invasive caries management techniques. At CareQuest, Jeremy is driving the development of better treatments, preventives, and diagnostics to improve access to person-centered care, integrate oral health into overall health, and stop dental caries. And we are grateful and honored to have him here today.
Thank you so much for having me. It's really an honor to be here. Thank you, Stacy and Annalise, for hosting, and everyone else who contributed, including everyone who's contributing the trust of their time. I hope to share some useful things. I am doing something a little rebellious to my history, which is that I'm not going to talk about silver diamine fluoride. If you want to learn more about that, contact me. I just put my email in the chat. Happy to do talks about SDF, but now that we are, 7 years plus into having SDF in the United States, I'm here to highlight a couple other non-invasive options that you may or may not be using. So next slide, please. Just by way of background, I now work for an organization called CareQuest Innovation Partners. We are a wholly owned subsidiary. We're part of CareQuest Institute for Oral Health. And our group is a for-profit component that tries to validate and scale new ways to improve oral health. So we're using sort of the the capital of CareQuest to invest, partner, and try to build change through collaborations with sort of across the industry, from inventors to payers to clinic systems, etc. Next slide, please. And by way of disclosure, we do have a financial relationship with a product that I'll be discussing. That is an FDA-approved product that we're talking about its use for the FDA-approved portion, but we do have a financial conflict of interest that I want to disclose. Also, personally, I'm on the advisory boards, I'm a key opinion leader for a couple companies that have relevant products, like glass ionomer from GC America, for example. Next slide, please. So these are the 4 topics that I'd like to discuss briefly over the next 18 minutes or so. I would just think that whenever we talk about cavities, caries, management of tooth decay, we need to talk about the answer that's been in front of us for well over 100 years. And it's like the hardest thing because of the way that our dental care delivery system is set up. It's also the simplest thing and the most effective. So food, the answer is food, we'll get to. And then we'll talk about a very simple technique that is profoundly effective for cavities in baby teeth, and 2 things that you might not have heard of before. One of which is probably sitting in your medicine cabinet unused for this purpose, and the other of which is pretty new. So we'll just very briefly go through what this is about. Thank you. So in short, we'll go through dental caries basics. So how do cavities happen? These are teeth, next. And this is dental plaque. I like to draw the plaque about the same color as the teeth because it's hard for a lot of people to notice it and see it. And so when you feed sugar to bacteria, next, you get acid, next. And I put a little pause in there to show, thank you, perfect, that it does take a little time. So it takes 10 minutes or so for the bacteria to convert the sugar into acid that then starts to dissolve the teeth. And that's caries, right? And our big factor that we don't normally think of, or that not everyone thinks of, is saliva. Not only the content, not only the amount, but also the content, the quality of the saliva. And when we think about what influences all of these things, what influences sugar, bacteria, acid, saliva, it's food. And long story short, if you look back historically, populations that ate in their native ways did not have caries. They just didn't. And as soon as you start really over processing carbohydrates and making simple refined sugars, you start getting caries. Next, and hold here, please. And the point here is that the food actually influences all of the factors of caries. It displaces sugar. It can balance sugars. For a while now, we've known that it templates what bacteria you have. And by eating foods that are heavy in arginine, or yes, toothpaste that has high amounts of arginine in it, like 1.5%, you can change the bacteria that are in your mouth. We've played with xylitol, obviously at certain ages, it seems to be effective. We can buffer the acid. We can not make acid by not feeding sugar. And now there's stronger and stronger evidence that nutrients like vitamin D really inform the quality, content, and prevention of caries by our saliva. So there are mechanistic bases for all sorts of different nutrients and food in general to modify caries and prevent it completely or cause it completely. And so I would say it's no overestimation, no exaggeration to just say that caries is a disease of malnutrition, that it's the wrong food. And this is, so important in our rural areas because food access and food focus has shifted so dramatically in the last 40, 50 years from being agrarian, self-sustaining, where people grew their own food, to now being reliant upon mass-produced, overproduced, non-nutritious foods, period. Next slide, please. There's a great book. There's a few good resources out there. If you ever want to read a big tome, we got, should already have this on hand. This is a fantastic book. If I can, there we go. Nutrition and Physical Degeneration. It's just a long one. It's like 700 pages. So my friend Roger Lucas wrote this great book, and it's just really simple. I love it. More chocolate, no cavities. Shows you how to actually change your diet to keep yourself and your kids cavity free. And oh, by the way, you'll probably also prevent diabetes and obesity and most aspects of heart disease. One of the things that I hadn't realized until I read this book, I don't know, 8 years ago, was crackers. That crackers are really, this overproduced carbohydrates that cause caries just as much as sugar in our population. It's just dramatically overlooked. We're just feeding it to kids all the time, in particular. Next slide, or sorry, next picture. And so this is a picture from my clinic where I saw this pink stuff in the kid's teeth. It was about 11 a.m. and I was like, oh, what was the last pink thing he had? Oh, he had some crackers this morning around like 7 a.m. How'd you know he had something pink? Just like showed the parents. That happens like every day. They're just like crackers and they stay in there and fester and all that stuff. So yes, sugar, yes, sugar, yes, sugar. And crackers are sugar. They are. So if you can extend that to other aspects of food, then we can really start to understand the dynamics of this disease and how it works, that it's just over-processed carbohydrates. So we like to say rice is great, traditionally made pasta is great, crackers cause cavities. And that's kind of the balance that we see. It's also because of what you put on it and balance that. Thank you, perfect. No, that's great, go ahead. Always have to call out water. Water rights are a huge issue, in particular in rural areas and frontier areas where often access to clean drinking water, just like in the inner city, can be a huge issue. I would say that even in privileged areas where I get to practice, most of the kids that I see are they don't drink enough water, and you can see it in their saliva. You ask them, how much water do you drink a day, and they kind of drink when it's convenient. Us as adults, you should have a big thing of water nearby while you're sitting on your Zoom or, in your clinic break room. It makes a difference for your body. I'd say probably the most knowledgeable person in all of cavity research, the wife of the great Gordon Christensen, the brains of the operation. If you've heard of Gordon J. Christensen, if you're a dentist, I'm sure you have. If not, then maybe not. But she's the brains of the operation. And when we work together, she always reminds me that you should be drinking, what is it, your weight in milliliters or something. So you should be drinking like multiple liters of water a day, ounces, fluid ounces. So I'm supposed to be drinking, what is it? I'm like 200 pounds. So I'm supposed to be drinking at least 100 ounces of water a day. She says 200. But that affects our saliva. It displaces the sugar. The nutrition that's in water is really critically important. Next. And finally, for the food section, just to let you guys know, if you didn't already, that a lot of the top FQHCs, a lot of the top health centers in the country are devoting just as much space to teaching kitchens as they are to dentistry, because they see food and nutrition as equally or more important and more fundamental to health than fixing teeth, than managing diabetes, because it's upstream and they recognize that food is the cause, or malnutrition is the cause of these non-communicable diseases. So I challenge you to talk to your patients or have your providers talk to their patients about food. And I like to say only good things can come from talking about food. Sometimes people will bring you food. Sometimes you'll learn a recipe. Sometimes you'll challenge a young person to grow something with their own hands for their first time and engage them in food. So I think that is more important than stuff that we do to teeth. And that's why I started with it. Okay, now, just like to say, we have been creating a resource at CareQuest to try to demonstrate the procedures and enumerate the procedures in non-invasive dentistry, in treating cavities or preventing them without taking away any human tooth structure. Next slide. And so we are building this out. You can see a couple of illustrations in this slide with the disclosure and the purpose and all that kind of stuff. But I will be showing a few of these and hope to tease you that this is coming soon and we're very excited about it. And of course, you can use the ones that are in the slides that will be distributed to you. And you're welcome to contact me if you want to use more. It's great. So now for the 3 techniques that I will be spending the rest of my time, of our time together on. Hall crowns, Hall techniques. So there is a procedure called the Hall technique for stainless steel crowns. Next slide, where you take cavitated Caries lesions that are asymptomatic, where you don't have an abscess, where you could push on the tooth and the young child doesn't jump out of the chair. There's no sign of infection, but you can have a big hairy cavity like this one. And next, you find the right size stainless steel crown, shape it a little with your fingers or whatever you like, and fill it up with glass ionomer cement and put it on the tooth. No local anesthetic, no removal of any tooth structure whatsoever. And as I'll show you in the next slide, don't go forward yet, please. This is a lot of evidence supports this. It has come to the point where the international community has said we don't need more clinical trials on this technique, it just works. So that said, this is completely fundamentally different for any of the administrators, non-clinicians in the room. This is completely anathema to everything that we were taught in dental school, hygiene school, all that stuff. You have to take out every last bit of the bacteria, which you can never actually do, and leaving it in here. Usually when we're in person, I have someone asking a series of questions where the last question is, wait, but what? You know, because this is so crazy. Okay, next slide. So we have clinical trials. We have clinical trials to the point that we have seen clinical trials with general dentists doing this. We have seen clinical trials with pediatric dentists doing this, such as this one. So in this study, they compared the Hall technique. So there was baby teeth, cavitated Caries lesions, big holes, compared to traditional fillings done by board certified German pediatric dentists, looking 2.5 years later. And in terms of minor failures, which is like you have to redo the restoration, or major failures, which is like an abscess, there were less failures in the Hall technique approach than in the traditional approach. So that really challenged fundamentally our concepts of what fillings and restorations are all about, and how we achieve success. Next. And the middle portion, which I haven't discussed, is actually not removing any not putting any restorative material at all. It's taking a non-cleansable lesion, a plaque trap, and basically just disking it down, smoothing down the tooth around the cavity, and talking about nutrition and hygiene, putting some fluoride varnish on it. But basically the main difference in this group is that they smoothed it down. So the Hall technique is shoving a crown with glass ionomer cement over the tooth and not removing any tooth structure. This is not removing any tooth, this is removing tooth structure, but not putting any restorative material, just changing the dynamics of the local area and really motivating the patient to change their nutrition and hygiene. So this, of course, challenges sort of everything about dentistry at a very fundamental level. This kind of thing works with permanent teeth, but you just, the permanent teeth do not automatically self-adjust their occlusion like baby teeth do. Next. And so this is a illustrated how-to, sort of a comic strip, demonstrating how to perform this technique. Due to our focus and time today, we're not going to go through in detail, but just to show you that we have this, and there's a video that's been watched over 500,000 times. It's got to be the most watched dental video ever, where the URL is at the bottom of the screen there, the bit.ly Hall crown, case sensitive. So go do it. And then next should show that we do have descriptive words that are in there. So if you convert to PDF and distribute, please delete the block on there before doing so. It's okay. Next, povidone iodine. I think the next most overlooked technique that we have in oral health is using iodine for caries prevention. Next. And this is literally the betadine that you have in your medicine cabinet that you use to disinfect wounds. I have a whole free course on this at the Elevate website, which I'll show in the next slide, but feel free to go do that. You can get your CE credits. We're trying to line one up to be done by CareQuest. But in terms of safety, basically, if someone knows that they have serious iodine sensitivity, don't put iodine on them, and otherwise it's generally extremely safe to put in the mouth. Very long story short, but I don't say that idly. Next. So there have been multiple clinical trials, multiple comparative cohort studies, and the short of this forest plot is to say that if you keep putting it on over time, like every 3 months, 4 months, you get a preventive effect. We'll talk about how to do this in the next slide. It's very simple. But that's, you had prevention of cavities at the patient level, which is something that's not been demonstrated for anything else to my knowledge, not for fluoride varnish or anything. So what we do is we take gauze, clean the teeth, wipe the teeth a little bit dry, put iodine on the teeth, then put fluoride varnish on the teeth for any child with elevated risk or any older adult. I do that for my kids instead of sealants periodically. Next. One of the things that we learned is that there's a couple clinical trials where they put it on once and never again, and it did not have an effect in those studies. Next. And the rest is with fluoride or without. So this is with the background of fluoride varnish. The control group had fluoride varnish, the treatment group had iodine and then fluoride varnish, and the black diamond is not overlapping the line, so that means it worked. Next. And then the next 3 trials were in very young children, like 1-year-olds, 2-year-olds. And there was no fluoride in the background, so it shows that the effect is not dependent on fluoride. There's a bunch of animal studies and microbiological studies showing that they work together in the lab. We're not the lab, so nobody really knows what's going on there. But it seems to work as long as you keep putting it on over time. The most seldom that's been done in clinical trials is every 4 months. Obviously, we want every 6 months because that's the sort of routine, but people can do this at home. Next slide. Oh, right, there's the URL for the course, but we will distribute these slides so you can do that if you'd like. Up to you. So this is the technique, again, just very simple, thank you, is that you dispense a few drops. I like to use 8 drops, use a cotton swab or a Q-tip. You just remove excess saliva and you paint this on. You can keep the mouth open for 10 seconds afterwards if that's all you're doing, or just go ahead and proceed with fluoride varnish. And just wait the same amount of time that you'd wait for the fluoride varnish to eat or drink. Next. I did convince, oh right, and then in terms of some myths, the shellfish iodine allergy is not, it's not real, it's a myth. It doesn't taste bad, tastes a lot better than most fluoride varnishes, and there's no stain to the teeth. And I did convince Elevate, next slide, or next portion, to make a product, which hopefully will become available soon. CDT code 9630 if you're selling it to patients and distributing it at home, and 1355 for application in the clinic. That's prevention by tooth. So kind of pick which teeth you want to bill for or document. Next slide. And Curodont. So finally, we're just going to do this really quick. It's a new procedure, new material. We're excited about it. Next. And just to say that it's proceed one more time. Sorry, my fault. Thank you. This is a peptide. Which, sorry, the amino acid sequence is scrambled on the left, but it's a short little peptide, a little protein that soaks into initial caries lesions. So white spots as far down as the outer third of the dentin, as long as there's no frank hole that's letting bacteria into the tooth. It absorbs in, it self-assembles into a scaffold that then templates the formation of hydroxyapatite or fluoroapatite throughout the tooth, throughout the lesion. So it soaks in, it forms these long fibrils, and then it uses the calcium and phosphate from the saliva to make enamel where it's missing. Next slide. And so we have just recently completed a systematic review and meta-analysis with an international group of experts, outside experts, and found that there is a statistically significant difference across multiple clinical trials that look at stopping cavities with this stuff compared to control. Some of the studies have fluoride varnish, some of them don't. Fluoride varnish seems to help, but it's not dependent on that, and it's over the effect of fluoride varnish. It doesn't stain, it doesn't taste bad. It's new to the US, and it is not yet cheap, but our focus on this is to make this less expensive, more efficient, for the Medicaid population in particular. And next slide. And so this is just to show how to do it. So you do clean and etch the tooth and then rinse, dry, and apply. So it is sort of one extra step is the etch step beyond what you would do with SDF. But it doesn't stain, so there's an advantage there. You also do wait a couple minutes for it to soak in. So by way of introduction, that is Curodont repair. And next, we will end, and I will stop there for interaction and questions from the chat or otherwise. Thank you.
Great, Jeremy. Thank you so much. And you snuck in an answer to one of the questions in there about the CDT codes.
Sorry.
Which is fine, totally fine. There's a request. Do you have a reference for the systematic review on iodine?
Haven't published it yet. Good question. I will. Yeah, I haven't published it yet. My apologies. If anyone wants to help, come help. But I'm happy to send the references for the clinical trials that are referenced in that work.
Great, thanks. And we'll include that in the follow-up distribution. Other questions for Jeremy? Scrolling back to make sure we didn't miss any others. Feel free to pop it in the chat, or if you want to take yourself off mute.
I know that was a rushed run through.
So when do you think Curodont will be available?
Great question. So Curodont is available through a company called Young Innovation now. It is about $30 and you can apply it to up to 3 teeth. We think that that is prohibitively expensive. And so we are working with the company. Our whole partnership is about getting it to half that price, and that you would be able to apply it to as many initial caries lesions as the patient has. So 10, 12, et cetera. And so it'll be about $16 or so, also through Young Innovations at by January of 2023. God, is that coming soon? It's crazy. So about 6 months from tomorrow, or 7 months from tomorrow, it'll be a lot cheaper. And if you're interested in doing collaborative research projects, please reach out to us, because we can get it for free or cheaper or whatever. So.
Jeremy did post the CDT codes in the chat, D1355 for iodine for clinical application, and D9630 if distributing for home use. Other questions? You answered every possible question that could have been, Jeremy.
I think Dr. Ross asked, or sorry, Gabriel, breaking rules, asked something about how can we get this breakdown of Hall crowns on a PDF? Oh, I see you sharing the slides. That was already answered. My apologies. Okay, great. Well, thanks everyone. Thanks for having me.
Dr. Jeremy, I just want to leave a comment because my name is Tahir Farid, and this is really brilliant because one of the first line of defense is empowering the patient by giving them the tools to go ahead and start triggering or treat these teeth they suspect to be infectious. So this is really brilliant, and you got all my support. I truly love it. 6 months ago, all the support. We'll do whatever it takes. Thank you so much.
Thank you. Anything else before we move on to our case presenter? Okay, thanks again, Jeremy, and thanks to folks for their attention and participation with questions. So it is now my pleasure to introduce Denise Helm, who is a professor and PI of the Rural Health Program at Northern Arizona University, who is going to share a case with us today for our thoughts and recommendations. Denise.
Thank you so much, Stacy. It's a privilege to be here, and it's definitely a privilege to follow Jeremy Horst in our presentation. So thank you for having us today. And our project is, we are part of a smaller group, and it is a grant-funded project funded by the Arizona First Things First. Included other stakeholders are Sandrose Consulting. We have access to baby and children dentistry out of Washington. We have North Country Community Health Care and the Arizona Dental Foundation Give Kids a Smile that are all part of this project. The overall goal of this private public partnership is to increase access to care for young children in Navajo and Apache counties in Arizona. Our role is to work directly with the providers. So we are working one-on-one with the dentist, and we provide technical assistance, consulting. We offer resources. We provide continuing education. And we're using a data-driven approach to accomplish that. And what I mean is we have our Medicare state data for the dental claims for the last 5 years. And we use those data to identify the providers who are most likely to increase providing care for young children. So we look at their history and we kind of look for the low-hanging fruit, so to speak, and we decide which ones would be most suited to work with this population and may need additional assistance that we could provide for them. But the challenge that we've run into is that we haven't found a lot of dental offices that are interested. So we are bringing this project to you, and we've worked on other projects before in the past that we've had grant funding for, and they've had learning seminars similar to this where we've presented cases, and we found that we've learned so much. So we're excited to hear from the group on any suggestions. So Stacy, you can go ahead, next slide. So what are we doing now? We're currently using a warm handoff. And what we mean by that is we are working directly with hygienists, other people in the community who know these dentists. And we ask them to introduce us to the dentists and say, you know, here's the group from Northern Arizona University. They're coming in. They would like to provide you with assistance. And we're trying to be particularly sensitive to the fact that we are not dentists. We don't claim to be dentists. We recognize that they had training on how to treat young children when they were in dental school. But we're trying to share our area of expertise. I've been an educator for over 34 years. I've worked in a pediatric practice in the past. So we're coming to them saying, we have specific expertise that we'd like to share with you. We understand that you are already skilled in these areas. So our question to you is, how can we better engage these dental providers in these two counties? They're rural counties. It might be important for you to know it's a little different culture than a lot of other counties. So that's our question. So I guess open it up for clarifying questions. Does anyone have any clarifying questions?
Oh, look at you go. Thank you, Denise, for just carrying that forward.
Sure.
Any clarifying questions for Denise? So we're going to be going into breakout rooms in a moment. Denise will not be in all 3 breakout rooms. So wanted to use this time for any clarifying questions, and then we're going to go into the brainstorming problem solving piece to come up with some recommendations. If questions do come up, we can reach her through cyberspace here in the breakout rooms, but wanted the whole group to have the opportunity to hear her clarifying answers to anything you're wondering.
And Stacy, I'd like to add, I was rather remiss. I didn't introduce my colleague, Katie Mummertz, who is here also, and she can answer questions as well.
Thank you. And thank you, Katie, for being here with us.
I do have a quick clarifying question, Denise, for you. With your resources and continuing education that you offer, are those things, are they already made and you're kind of offering like, here's what we have? Do you have pre-made things, or are you kind of trying to figure out what they need and then you're going to make them? Just wanted to clarify.
We are doing the latter. We're identifying what they're interested in. And in fact, we've sent out a survey and got a relatively good response from the survey to identify what kinds of things they're interested in. One of the things that came out was that they're interested in motivational interviewing. So for example, we're doing a continuing education seminar later in June, the second week in June, on motivational interviewing.
That's really helpful. Thank you.
Okay, so we're gonna go into our breakout rooms momentarily. And, oh, people are already on their way. Okay, we're gonna be in there for, I'm gonna say 12 minutes. So then we can come back and do some sharing. So we'll come back at 1:50 Eastern time.
If you did not get a breakout room request, it's because you're here with us in the main session.
Woohoo. Should I be here, Annalise? Yes, okay. Okay. So I'm going to be so bold as to ask folks, if you're able to turn your camera on, it would be really wonderful to see your faces. Not surprisingly, we feel like the conversation is all the more robust when we can see one another and interact in that way. So if you're in a place where you can turn on your camera, thank you. That's great. So I'm going to post in the chat. Thank you, Don Weaver. Oh, we had you and then you left. There he is again. Okay. So our charge here, and thank you, Jorge, as well. And Francine, you were on the whole time, so I want to give you credit. Thank you. How can we solve the problem? How can we think about it differently? And who or what is missing from the table? So as you'll recall, the primary question is, what can they do to better engage their providers? They want to provide technical assistance, but they seem to not be, the providers don't seem interested in having them come and do that. Any preliminary thoughts?
I sort of heard a general overview that they wanted to reach out. You know, whenever I've been in a situation where I think I'm offering something that would be needed, try to go back and reflect on how am I framing the message. And probably that's field testing it with a few people, perhaps outside of those two counties, just to say, if someone came to you and said, you know, what would you find of value? Is there anything in the message that, you know, and I don't know. I mean, it's, I have a dear friend and colleague who said when it was so easy to say a patient did not comply, as opposed to we haven't figured out the right way to reach them. And I think that may be one thing to take a look at. The other thing that came to mind for me is, since they're focusing on children, did I understand correct, from birth to 5, you know, who are all the people in the community who touch children from birth to 5? And maybe it's more of a coordinated effort. So it's, you know, more of a team sort of looking at it, that approach. So those are just a couple thoughts that came to mind for me, Stacy.
Yep. Thanks, Don. Other suggestions or experiences that folks have had doing this in their own communities or organizations?
I was going to say that the team approach, I mean, that's really it. It should start with the seeing their medical, they go to see their medical doctor, they do that. But it has to be conversation that starts. I talked to my CEO actually last week about this, trying to get patients to go. We're going to have a pediatric dentist soon. And he's like, the patients are here. There are a ton of patients here, but it's just having the staff there saying, okay, now go here, you know? But I mean, it seems like it's trivial and easy, but it's really not. And if the conversation is not had, if you've not met with the staff, you know, beforehand, behind closed doors, I guess, before they get to the medical doctor, then staff doesn't know to say, go here next or whatever. But that has to be, conversation has to be.
About the referrals, yeah. And so it's on both sides, right? It's how do you prompt demand by the parents that you have those conversations? I think I hear what you're saying, is what I think I hear you saying. And then is the question also on the supply side, right? How do you get dental providers more willing to see children in this age group?
One other suggestion, hi, this is Soumya here. So one other suggestion which I would like to say here is to have some focus groups. So they were talking about motivational interviews, but additional, they could also consider the use of focus groups to have both providers and you know, the team from the facility, you know, who where they see children. They could have some focus groups and get some ideas from there.
So focus groups with the providers or with the families?
It could be with the providers, a separate focus groups with providers, or if there is a place where there is a possibility of bringing both the teams together, that would be great. Like any events, any children related events where any providers could participate and get to know the expectations of parents and what the treatment needs are. Be a good idea.
Yeah, great idea. To what extent do folks think, when we're talking about the Medicaid population, do folks think administrative issues are a barrier? Do you think that part of it is, it's not for us to come up with this seems to be all the list of all the reasons why they don't want to do this, and certainly hearing from them directly. But I'm wondering, based on your experiences in your communities, if you've seen that, what barriers you've heard self-described by oral health care providers about seeing young children that maybe this group would want to explore. And Annalise and Jeremy, feel free to chime in as well.
Yeah, it's funny. I just got a similar question from like a global group that's looking at the same age group and asking, you know, what are the things that everyone should be doing? And it's, you know, to me, it's just sugar. So what do you do about sugar, right? So sugar taxes, right? Part of the Navajo has a sugar tax that could be done more places. And I think the leadership from the Navajo is incredible. And just across the border down in Mexico, obviously they have a national sugar tax now that's dramatically impacting consumption of sugar. Teledentistry is I think a big tool, especially for young children. As was mentioned earlier, I was kind of like 5 minutes late to our check-in because I have young children home sick with COVID. They're fine, everything's fine, but they can't go to school, right? So how do you juggle all that? Well, if you're telling me that I have to go in and bring my 3 kids to a dental appointment, then try to have a conversation with me about food and nutrition, like I'm going to be trying to keep my kids away from all the dirty stuff on the floor and the sharp objects that are everywhere and all that. I'm not going to be very focused. But if we have a teledental call, they can be, you know, taking whatever risk they want in their own home. And I can be much more focused on a call that's going to make a difference in terms of nutrition and hygiene. So I think that's been really overlooked for really young kids, like 0 to 5. Those are Me too.
Yeah. So I think what I'm hearing from you is you're not really responding with how can we get more dentists willing to see these kids, but I think what you're suggesting another way that we can get prevention to these kids and care to these kids in a way that doesn't rely on a local network of providers being willing to see them.
Translation. Thank you. Yeah.
Okay.
And also, I mean, you talked about they're seeing the medical folks 0 to 5, successfully. They're not seeing the dental folks. Well, if we want to do integration, maybe, is there someone who can speak to food and nutrition better, or at least as well from the medical side, who can then participate in preventing the disease that we see on the dental side?
Mhm.
One thing that we talked about at my site years ago, which never came to fruition because the OB director left, but we had a system that we kind of made up that was going to make the mom have to see the dentist as a part of her whatever the flow was. But it was just something that we made up. It wasn't like a real thing, but we made it up. But it didn't get any, like my friend who was the OB director, she left before we could get off the ground. But that was our plan, to make the mom have to come and get these things done and teach. We'll let her be seen, of course, and then train her as to what needs to be done with the coming baby. So as soon as possible, kind of get them. So my trick didn't work, but that was the plan for it. Like start from the beginning. Yeah, that's a thought.
Yeah, that's great, Don.
Stacy, you and perhaps several others will know as well. I think a lot of what we're talking about is who is on the oral health team and who's on the dental team. And I say that because we use those terms interchangeably, and at least in my definition, oral health is very much the broad team sport, from the community health worker or outreach worker all the way to the important elements that the dental team plays. And I think as we look at messages reaching this group, maybe it isn't, and maybe it's possible through telehealth, Jeremy. This isn't that they've seen the dentist or the hygienist. They've seen an oral person trained in oral health who is all part of this team, many of whom are much better than, certainly than I, in talking about nutrition and food. So I think looking at this interdisciplinary, interprofessional approach to it is what I think I'm hearing from folks, which then reserves the dental team, particularly for those children who really do need to see a dentist at a particular point in time, because the last time I checked, we're awfully short of dentists in underserved areas. So it's just, I think what I thought I was hearing, and I didn't, it fits sort of the definition I use of oral health versus dental care.
Yeah, thanks, Don, for sure. So I think, Annalise, we want to close out the room so that people come back to the main in a minute. I think if you do it now, we'll get that 60-second. Thank you. And Trell, what you said also made me think of the fact that we know that when adults have dental coverage and Medicaid, for example, and they're going to see the dentist, their kids are more likely to be getting the screening and preventive services they're supposed to.
Right. It starts with mom.
Yeah. Even dad.
Yeah. Well, dad is last. It's mom, kids, and then dad.
Maybe grandparents after mom and then dad, right?
Yeah.
Yeah. Jeremy, there's a question for you in the chat from earlier.
Thank you. Oh, Iodine?
Yeah, and there was also one even earlier from, have you heard of this being applied in a medical environment? From
Oh yeah, there's a few pilots. I assume that's iodine. That probably refers to Curodont iodine.
Yeah.
If you there's a totally. Just very briefly, yes, it's being done very sparsely in the medical environment. In particular, there are some native tribal health communities that have been doing it for like 10 years, just quietly, like up in Alaska, and a few other places. So it's being done a little bit. Do we recommend this for root caries? Yes. I mean, there are no clinical trials for looking at prevention of root caries, but presumably it works. It's an antimicrobial that works against caries, and there's no reason to think it wouldn't work in that scenario. It's very safe, and it's used for perio. A lot of hygienists put it in their ultrasonic reservoir, so we may be getting caries prevention from the perio application that we use. So.
Great. For those just joining us back here, Jeremy was responding to some additional questions we had in the chat from his earlier presentation. So we have him for a few more minutes. Well, I hope everyone had a fruitful and enjoyable conversation in their breakout room. It would be great to go around the horn and hear from people across the rooms about some of the highlights. And I will say that we are capturing, Denise, we captured notes from each of the breakout rooms, and we'll be preparing a summary sheet of recommendations, both for your organization as well as we'll share that with the full list of ECHO participants so everyone can see across the board what the full group's recommendations were. That being said, it would be great to hear some highlights, some takeaways from the conversations, anything that stayed with you, anything folks want to lift up.
Stacey, I can talk a little bit from our group if that's helpful.
Sure, thanks, Annalise.
So I will not share everything out because I felt like the discussion was really, really rich and really ripe with all kinds of suggestions. So I want to thank everyone in our group. But I think the two things I will highlight that were recurring themes were care integration and really thinking about the full spectrum of the provision of care and opportunities to integrate oral health within each one of those touch points of care. Thinking about where patients are already receiving care or may be receiving care based on the trajectory of their health and infusing oral health into those arenas or processes. The other piece, and I'm going to steal a line from Open, which is bringing care to the people versus trying to bring people into the care. So again, thinking about what's happening outside of that dental visit or thinking about opportunities to leverage dental visits toward more efficiency or thinking about the patient care needs and meeting people where they're at in their community, which I think Jeremy presented on quite a bit in terms of non-invasive care, right? Ways that we can just create health opportunities outside of the dental visit.
Thanks, Annalise. Any clarifying questions for Annalise and our group? Okay, folks from another group.
One of the questions that came from our group was, do we know why the providers in the area are hesitant?
Denise, you want to answer that?
Sure, we would love to know why. We don't know that. That's a great question. I think if we knew that, we could better address those things. So that's a good question.
Well, one of the suggestions that came from our group was to provide a survey to local organizations that are interested in the same work. And so maybe that could be a means to get that answer, why those providers are hesitant to, you know, want to embrace what it is that you're doing.
Thanks, Kiara. And a related idea came up in our group. We talked about doing focus groups, potentially involving both types of providers, medical and dental, and potentially including families to get an understanding of what their expectations are from a visit and from care. Others?
So our group also mentioned the surveys as well, but in addition to possible surveys and awarding CEs to sort of incentivize them so that dentists, you know, in those areas are more inclined to be motivated to be a part of it. So maybe like a small, like a $25 gift card or something like that. Other suggestions were partnering with the ADA and also with the State Oral Health Coalition.
Thanks, Jasmine. Anything else? And thank you, Don, for building on my comment in the chat. Annalise mentioned Open, which is the Oral Health Progress and Equity Network. And Don shared a link for how you can learn more about Open and if you're interested in joining. It's a great national network of about 3,000 folks working in various areas of oral health advocacy, care, policy, nonprofit. etc. That's my little plug.
Something that came from our our breakout room was that maybe we should provide educational materials to non-dental providers. And one of the examples was like maybe a child that doesn't know how to sit still within the dental chair. You know, just things that will help to, I would feel, cultivate that experience for children, and all children, differently able children, neurodiversity children within that space. So I thought that might be also something that you might think about.
Thanks again, Kiara. Well, if anything else occurs to folks, please reach out via email, and we'll include it in the case summary recommendation. I wonder, Kiara, would you mind popping that in the chat, the info email address? And folks can reach out there. So if we could go back to our slide deck, please. So next steps, CEUs will be available for today's session. We'll be sending out an evaluation and request form following today's call. As I shared, we'll also post the recording, any resources that were suggested, and the slides on the AIDPH website. And we'll also share a summary of the case recommendations. Our next ECHO session topic in June will be LGBTQIA+ rural oral health. We encourage folks to submit a case form if they want to present a case either on this topic or another topic over the course of the year. And as a reminder, you can earn a rural oral health certificate by participating in these ECHO sessions. If you attend, what's the number, Annalise? Is it 8? I think it's 8. If you attend 8 of all the ones.
I screwed everything up. Sorry, Stacy.
That's okay. It's 8. You need to come to 8, right? Yes, she's giving me a thumbs up. Attend 8 of these sessions to earn a certificate, and also complete the evaluation forms and quizzes, and you'll earn that at the end. So thanks, everyone. Thanks again to our presenter, Jeremy, also to Denise and to Katie, and to the whole support team here. And thanks, everyone, for bringing your best thinking today, and for folks putting their cameras on. We really appreciate that. Have a happy Tuesday and a short work week. Bye, everyone.
Thank you.
Thank you.